Thank you, Dr. Bhavitarini, for an excellent introduction. Good morning, everybody. So today we will talk about insulin therapy in special situation like pregnancy, where we have to not just balance the therapy for the patient, but also for the fetal outcome. So both the maternal as well as the fetal outcome, both we have to balance. So first, I would like to thank the organizers, Dr. Bansi, Dr. Manoj, Amit, everybody for inviting me here to give this talk. Um, so we start with hyperglycemia in pregnancy. In the last couple of decades, you have seen that hyperglycemia in pregnancy has increased in leaps and bounds, such that now 1 in 4 pregnancies is affected by hyperglycemia, which is a huge amount. And this is mainly because of the increase in the obesity which we are seeing over the last few decades. So it impacts the entire woman, not just for that period, but even for the future. I'm sure you'll have heard about all the things that happen due to the hyperglycemia which occurs in the pregnancy. There also is a link between obesity and gestational diabetes. There is a rise in the obesity rate, and this person in the future will develop diabetes, type 2 diabetes, as well as there's an increased cardiovascular risk in the woman. There are many things which happen in the fetus. There are a lot of potential adversities, outcomes in the offspring, which are exposed to the gestational diabetes. In the fetus, there could be malformations, there could be stillbirths, there could be choriona amnionitis, birth asphyxia, preterm birth, macrosmia. Subsequently, there could be large for gestational age, birth injuries, hypoglycemia, which occurs. Later on, this child can have neurodevelopmental impairments, obesity, increased adiposity, impaired glucose tolerance, and potential to become diabetic. Also, with a lot of obesity. Now, the short-term complications during the pregnancy, of course, what we worry about is the preeclampsia, microsmia, large for gestational age, prolonged labor, and cesarean is usually the best way in case of delivery. Long-term, of course, type 2 diabetes and cardiovascular disease. The development effects which take place during the pregnancy, which make the woman or rather the fetus more susceptible to a hyperglycemia event which occurs. There is a central role of the fetal insulin in the pregnancy, which determines the fetal outcome. Um, However, the fetal insulin has a central role. It affects the body system during the various stages of development and growth. Maternal outcome also is there over a period of time. There's an increased risk of maternal metabolic and cardiovascular disease, and possibly due to the factors present, the pre-pregnancy and early gestational diabetes. Insulin secretion and resistance which occurs during the pregnancy. There is an increase in the insulin secretion as well as the insulin resistance, and this occurs across the trimesters. And there usually is about a 40 to 50% increase in the insulin resistance. As you can see, the various phases of how the changes in the insulin resistance do occur. Uh, the diagnosis, I think Dr. Bhavatarini would have spoken a lot about how we diagnose these people with gestational diabetes. There are various methods which are used for screening. It's very important to see that we detect early, we screen them at an early stage so that the outcome is better. This is the algorithm in which is used usually for screening. The DIPSI process, as we all know, is the one-step process which has been universally accepted by a lot of people. I won't go into too much detail of this, but this has been spoken by many other speakers. Management of diabetes in pregnancy. So first we talk about lifestyle management. which would include diet and exercise. However, the challenges that we do face in our country is the limited testing supplies which are there, the time-consuming screening which is there, resource scarcity, the cultural obstacles which are there because every mother or mother-in-law says that the pregnant girl has to eat something or the other as per their requirement. However, sometimes in our country, we do also find that there is inadequate or rather inappropriate nutrition, financial constraints to play a major role. 65% of the health professionals were unaware of gestational diabetes. So we hope that now a lot more people will be aware of gestational diabetes and detecting it at an earlier stage. The principles of managing it is a coordinated approach. We should, of course, reduce the risk and complications of and minimize the maternal and fetal morbidity. The glycemic control is what we work at, of course, that is very important. The nutrition therapy, physical therapy, if they are allowed to do some exercise, light exercises should be advised. Um, this initially we can give for about 2 weeks to see that we are able to manage that. If not, then insulin is the next choice. It should be advised as per the blood sugar levels. Um, Now we come to those who are pre-existing diabetics, especially type 1 diabetics. Pregnancy is a ketogenic state, so we have to be very careful that these women do not land up with ketosis. They have to, and even in type 2, sometimes they can come to us with ketosis because of the increased requirement. Insulin should also be used. Of course, in type 1, of course, insulin would be already used. And this is the preferred treatment even in people with type 2 diabetes. Optimal glycemic targets are what we need to see to it that we achieve. So the American Diabetic Association says that the HbA1c should be less than 6.5 in early pregnancy and 6% in the second and third trimester. Those women with type 1 diabetes, insulin analogs, of course, are the first choice as compared to human insulin. It gives better flexibility and reduces the risk of hyperglycemia. Like I said, first the target should be lifestyle. Even in women with type 1, the lifestyle element is there, but they need to eat minimum calories of 175 grams of carbohydrate with low glycemic index. There should be regular physical activity. Avoid excessive gestational weight gain, because in India, once a woman gets pregnant, they think that they have to start eating quickly, and in that case, they gain a lot of weight. So this is something that we need to start right from the beginning, whenever the person is in contact initially, and not just the women. We have to sensitize the family also that you do not need to keep forcing her to eat things which are not really required. Then the psychosocial aspect, the support from the healthcare team as well as the family is very important. Technology, if they can afford continuous glucose monitoring, is the technology of choice that we need to use. Insulin pump is something that we should consider. And hybrid closed loop for insulin is also what we need to look into. Then the complications, we have to prevent hypoglycemia as well as hyperglycemia, and screening for retinopathy is very important. Preconception counseling, especially in women who are type 1 or type 2, we need to see to it that if they are planning a pregnancy, they should probably see the doctor before, at least about 12 weeks before, so that they are able to maintain a euglycemic status. Subsequently, the chances of their getting pregnant are better because the organogenesis, we all know, occurs in the first 8 weeks, and that is the time when the sugar should be well controlled. Um, the glycemic goals, of course, are much stricter during pregnancy. The fasting sugar should be between 70 to 95. 1 hour postprandial should be between 110 and 140 milligram per dl. 2 hours should be between 100 and 120 milligram. And the recommendations for hypoglycemia thresholds also, the blood sugar should not go below 70. Um, Continuous glucose monitoring also is something wherein the time in range should be more than 70%, wherein they are maintaining the blood sugar between 63 to 140. The time below range should be less than 1%, level 2. So, when do we consider it? Of course, 90% of women with gestational diabetes do manage well just on lifestyle measurements. But for those that require treatment, insulin, as I said, is the treatment of choice, uh, especially women with pre-existing diabetes, overt diabetes. The trial after giving lifestyle measures for about 1 to 2 weeks. If the target is not achieved, that is when we start them on insulin. Um, it's like I said, it's the first line of treatment. The total daily requirement should be calculated as per the weight. The formula is there. You can multiply and calculate the dosage and give them adequate insulin. Um, those who are pre-existing type 1 or type 1 insulin, their requirements will also increase. Of course, during the first trimester, wherein they're having some amount of nausea, vomiting, they increase those requirements might reduce also. But however, later on, it will increase. These are the various types of insulin which are available, which can be used safely. Basal analogs is now considered safe to use and easier to use. Of course, it always is the choice which one should we use. All of them are pretty safe and good to use. The standards of care, insulin, which was studied in the RCT, over these have insulin is what the treatment of choice. Insulin, of course, has a lot of external insulin has a lot of effects also. There is a slight increase in the HbA1c initially, the higher risk of labor induction. There is a higher cord blood C-peptide which is there, and various other hormonal derangements which do occur. But the chances of delivering normally is what we are always looking for. We want to reduce the chances of hypoglycemia in the fetus as well as hyperglycemia. Now, the ADA recommendations, of course, say that insulin, preferably glargine or detonate, whatever is available. So we have been using it in India also for a long time. There are various trials which have been shown that this is something that can be used very safely. Now we come to bolus analogs, which are there. Insulin aspart is what has been used extensively. Of course, we all started using plain insulin, and that also works very well. Subsequently, the analogs do much better. They do reduce the postprandial blood sugars as well as they reduce the major hypoglycemia events. Uh, Then we come to insulin pumps. Insulin pump, of course, if financial constraints are not there, then insulin pump and continuous glucose monitoring is what would be recommended. The benefits in women with type 2 diabetes is that the HbA1c is definitely better, lower risk of hypoglycemia, and no risk of severe hypoglycemia. We need to consider when the glycemic control is inadequate and when there are frequent hypo and hyperglycemias, especially when there's hypoglycemic unawareness. Counseling is something which is very important. the nutrition, the SMBG, dose titration, sick day guidelines is also something that we need to consider, especially when they're in the first trimester. So monitoring and delivery, immediate postpartum. Okay, let's summarize with diabetes, of course, is associated with increased adverse pregnancy outcomes, and insulin is the mainstay for the treatment. Glycemic targets are, of course, much stricter, tighter, and it's better to start early and see to it that they maintain this. Thank you.